So we are going to finish the slides that we have from yesterday's PowerPoint. Okay, there. You have a representation of what we call the cardiac cycle. You have the systole and the diastole. That's something that is not new. Okay, when you are auscultating a patient, you are going to listen to the sounds locked up, sound 1, 2. Okay, between these two sounds, S1 and S2, we have what we call the systole. Okay, you can know when systole is occurring by auscultating the patient, locked up, everything after the dub and during the dub and the S1 is the diastole. Typically, diastole is longer. Okay, it's the longer part of the cardiac cycle, is 2/3. Okay, systole is 1/3 at rest. Okay, when we have an increase in the heart rate, the diastole time goes down. Okay, and there is a moment if the heart rate is very, very, very high, let's say 120, 140 beats per minute, the diastole and the systole may be equal in duration. So every time we accelerate the heart, we do it at the expense of the diastole. And diastole is a very important time for the cardiac cycle. It's the moment when the myocardium gets blood. Okay, when we are contracting the heart, the muscle of the heart is very stiff, contracted, so it's not getting blood. When the heart opens up, when the heart relaxes, is when the blood enters through the coronary arteries. Okay, so let's say someone has a heart rate of 60 per minute. Okay, it's a 1 beat every second. So 2/3 of that second, okay, is the time that the heart gets blood, the myocardium. If we start accelerating the heart, instead of 2/3 of a second, we go to half second, less than that. That means, imagine that you are working 8 hours per day and making $20 an hour. And the manager tells you, okay, starting now, you're going to work 16 hours per day and you're going to make $10 an hour. Doesn't sound like a deal, no? Well, that's exactly what happens when we have tachycardia. Okay, the heart is working twice as much and it's getting half of the blood that it normally gets. That's why tachycardia only can be sustained for a little bit. Okay, after that it's going to be complicated for the heart to continue working. Now, if you don't have a stethoscope, how do you know when systole is occurring? You simply take the right radial pulse or the carotid pulse. That moment, okay, when you feel the bump in the pulse, that's S1. That's the moment when systole starts. So, for example, if a patient has a murmur and you auscultate the patient and you feel a murmur, okay, is this murmur systolic or diastolic? Sometimes it's easy because you can listen S1 murmur S2. It's a systolic murmur. Or S1 S2 murmur. S1 S2 murmur. It's a diastolic murmur. Sometimes it's not easy. Sometimes the murmur is so long or so harsh that you don't listen to the S1 and S2. You feel Z. Is that systolic or diastolic? Well, if it coincides with the pulse, it's a systolic murmur. If you have the pulse and murmur, that is a diastolic murmur. So these are the things that we need to start understanding. And also, we need to know what happens in the heart in the different moments of systole and diastole. Okay, and that's why we have this representation, this diagram of what we call the pressure volume loop. Okay, that represents many of the events that occur in the heart. Okay, pressure volume changes in the cardiac chambers. Okay, to understand these diagrams or these loops, it's important to situate yourselves. What are we looking here? This is a diagram that plots, as it says, pressure, okay, in the y-axis and volume, okay, in the x-axis. We are looking at the left ventricle, what happens in the left ventricle, and there are different points. Okay, we have a point A, a point B, C, and D. That tells you that you have to look, it's better to look at this loop in this direction, counterclockwise, and understand what happens here, 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 and there with the pressure and the volume in the left ventricle. You can start anywhere, okay, but we try to organize ourselves, and we normally start in the simplest part, in the A, in the 0, okay? Notice that we have a 0 here. We have here 120 volume, that means milliliters. And here we have another 120, but this is pressure, this is millimeters of mercury. Okay? It's a coincidence that there is 120, maybe, but like that we have the 0, 120, 120. Okay? That means that at certain point we have 120 milliliters of blood inside the ventricle, and at certain point we develop a pressure of 120 millimeters of mercury, okay, in the ventricle. It goes down. So we're going to look at the different points, what happens. Now you see that I have represented, okay, these two lines in red and this part here in blue, because these are the two different phases of the cardiac cycle. Okay, the one in red, the one that starts with the V and goes down and then moves to the right and has this little bump here, in which you see an increase in the volume and a decrease in the pressure. That is the diastole. Diastole, the heart relaxes. Cavity opens up. Starts getting blood from the atria, from the lungs, in the case of the left ventricle. So we have a decreased pressure, relaxation, and an increase in volume because the heart is filling. Now, when you look at the look that you have in the PowerPoint, you're going to see here a straight line. That is good to understand what happens in the ventricle, but it's not totally accurate. At the end of the diastole, there is this little bump. So the volume of the ventricle goes up and then suddenly increases a lot. That is what we said yesterday about the contribution of the atria at the end of the diastole, pushing more blood there. That is what we call the atrial kick. Okay? The atria, when they push blood at the end of the diastole, they make that sudden increase in the blood. Okay, so at the end of the diastole, we have 120 milliliters of blood inside the ventricle. So this point, very important, is the end diastolic volume. Normally it's 120 milliliters of mercury. It will depend on the size of the heart. But everybody has the size in the same of this heart of the same size. It's not going to be true in a newborn. This is the average 70 kilograms person with a normal heart. If someone has a hypertrophic heart, thick walls, is going to be lower than that. If someone has a dilated heart, it's going to be more than that. We are talking about physiology. So what do we have at A? Okay, we have the moment when the pressure in the ventricle goes as low as possible. Remember, the ventricle, the lowest pressure that it will have is typically 10 millimeters of mercury. So that 0 should be down here. Okay, mercury, not hydrogen. Millimeters of hydrogen, no, what's that? Okay. At that point, okay, we are going to have the heart starting being filled with blood. Blood flushes. There is no valve between the pulmonary veins, okay, and the atria. But what we need here is to have the mitral valve open. Okay, if the mitral valve isn't open, you can have the blood going into the ventricle. Okay, so that is what happens at that point. Then the ventricles fill. We have the contribution of the atria. Okay, the atrial kick. The kick of the atria. And now we have here a very important point that in which we have the end diastolic volume and we have an increase in the pressure now. It goes straight up. Okay, there is an increase in the pressure, but notice that the volume doesn't vary. Okay, this is a period, okay, that we call isovolumetric contraction. Why we call it contraction? Because the pressure is going up. If you compress a liquid, if you compress a fluid, the pressure inside, okay, that container increases. You take a balloon that has a fluid inside, water or air, and you squeeze the balloon, okay, hopefully it doesn't pop. But we are increasing the pressure by squeezing it. Okay? So we increase the pressure, but the volume doesn't change. That's why it's called isovolume, same volume contraction. Now, what has to happen for us to increase the pressure and don't vary the volume? The valves, both sides of the ventricle, entry and exit, they have to be closed. Okay, we said the mitral was open here. Now we have to close the mitral. Okay, so at this point the mitral closes and it produces a sound. If I open a door, and it's a good door, it typically doesn't sound. When I close it, it will sound at least a little bit. Okay, when I open a valve, it doesn't make any sound. When it closes, yeah. So we have there the closure of the mitral valve that will produce a sound that we call S, or sound 1. Okay, the love. That is the beginning of the systole. Systole starts here with the isovolumetric contraction. Okay, there is a moment when the pressure inside the ventricle goes above the pressure that we have in the aorta. Remember the diastolic pressure of 80? When the pressure in the ventricle goes from 10 to 80.01, the aortic valve opens. Okay? So at this point, at C, we have the aortic valve opening. Okay? So we now have the blood going out of the ventricle. That's why we still have an increasing pressure, but the volume is going down from 120 to 50. 50 milliliters, which is the end systolic volume. Okay? You have the end diastolic volume here, you have the end systolic volume here, you have a period of rapid ejection and then slow ejection. The ventricle is getting empty. Will never get totally empty. There is always some fluid inside the ventricle at the end of the systole and systolic volume. So, and remember what happens if you subtract 50 from 120? What you have? The stroke volume. That is all the blood, okay, and diastolic volume minus end systolic volume. Okay? The systole, aortic opening, you have the ejection part, rapid, slow, okay? And then we have a moment when the ventricle has contracted, okay? All the force that it can develop, there's a moment when it's impossible to contract it anymore, and the ventricle starts like depolarizing and relaxing. Okay, so now it's unable to develop much pressure. Okay, and we are going to have at this point the closure of the aortic valve, and that will produce another sound. That is what we call sound 2 or S2 or dub. So you have the lub, S1, contraction with same volume, isovolumetric contraction, ejection, closure of the aortic valve or S2. And now we have the two valves closed and the ventricles relaxing. It's like if you have a closed container, mind you have a syringe, and you put your finger in the tip, and you pull, okay, from the envelopes. You are getting a vacuum inside the syringe. Okay, that is what is happening there. You have the ventricle relaxing, and the two valves, AV and aortic, are closed. You are creating a vacuum inside the ventricle that lowers the pressure inside the ventricle. That's why you have this pressure going down from 120 to 10 without any change in volume. That is what we call isovolumetric relaxation. Okay, until the pressure is so low, that is below the pressure in the atria. The atria overcomes that pressure, okay, in the mitral valve, and the mitral valve opens, and we have the beginning of a new cycle. Okay, those are the things that happen in this cardiac cycle. Okay, and when you prepare for exams, if you know exactly what is going on at these different points, what type of questions you have? Okay, what happens between the D and A? Oh, that is the isovolumetric relaxation. What happens between A and B? That is the filling of the heart. Okay, that is the filling, ventricular filling. What is this? The atrial kick. What happens at B? The closure, okay, of the mitral. What do you hear? The S1. What do you expect to find in the EKG? Do you remember what happens in the EKG at S1? What waves, what complex occurs there? We said that the P is the contraction or depolarization of the atria, and we have the P here. Okay, what here? What is this? The QRS. Okay, then we start having, okay, while this blood is going out, remember, repolarization, depolarization is something that is like almost one after the other. Okay, the tip of the heart depolarizes, the depolarization goes from the tip to the base, and when the depolarization is going through the middle of the ventricle, the tip is repolarizing. Okay, so during this period, we start having some areas of the ventricle that are depolarizing until the total depolarization occurs here. So you will have the AST segment around this part here. Okay, then you have start of a new, okay, contraction. Okay, there is another type of diagram that is similar to this, but it doesn't make a loop, okay, that we are going to be seeing. So this is what we have here. You have the different phases of the cardiac cycle, okay, now represented, okay, forming this loop in which you can see the situation of the different chambers. For example, you start with the atrial systole on top, you have the contraction of the atria, then you have the isovolumetric contraction. Notice that the two sets of valves are closed, squeezing the blood that is inside the ventricle. There is a moment when the pressure inside the ventricle is so high that it will push open the aortic valve to start the ejection of the blood. Okay, and we have this period of ejection, fast, slow. Then you have the isovolumetric relaxation, okay, beginning of the diastole, creating a vacuum inside the ventricles with the two sets of valves closed. Okay, then you have the opening of the mitral or atrioventricular valves, and we start having the filling of the ventricle. Okay, you can start at any point. Okay, you can start in the A, or you can start in the atrial systole. It's a cycle anyway. And this is the diagram. Okay, in here, this loop is very good. The only thing that is missing is the little bump. Okay, that I always like to represent there. Okay, it's perfect for studying. You can ask the little bump there, telling, okay, there is the atrial kick that contributes to the final moment of the ventricular filling. You have the end-diastolic volume, you have the opening of the aortic valve, would be our C here. You have the ejection, then you have the D here, that is the closure of the aortic valve. You can add the details that are missing here, S2 for example here, S1 here. Okay, all the things that you want to add there. Mm-hmm.
Is this the same for the right ventricle or?
Yeah, it's the same, but typically study the left. Now, another way of representing, okay, the cardiac cycle is this one. Okay, once you understand what happens in the pressure volume loop, you are ready to analyze, okay, something like this. Okay, here you have exactly the same, but instead of creating a loop, okay, you can see what happens, for example, during the atrial systole, isovolumetric contraction, ejection, isovolumetric relaxation, filling in the atria, in the ventricular pressure and volume. It's important to have clear what you are looking at. For example, the first part is pressure. Okay, the second part here is the aortic blood flow. The third one is the ventricular volume. You can see what happens with the heart sounds, venous pulse, and the EKG. Okay, and for example, you take one of the phases, no, atrial systole. Okay, what can we see during atrial systole in the pressure? Okay, in the ventricular pressure, you see that is going down. Okay, and here we can see the left atrial pressure that is going up. Of course, if we are contracting the atria, the pressure in the atria is going up. Okay, you can see what happens in the aorta. Actually, nothing is happening there. Okay, ventricular volume is increasing. Remember the little bump? Okay, you have the little increase in volume. Okay, and is there anything happening in the heart sounds? Physiologically, nothing. Okay, there could be an extra heart sound that we call S4. You're going to be learning in pathophysiology. Okay, notice that it's just before S1. Okay, and what we have in the EKG, well, we have the P wave and the segment. Okay. Okay, remember the period while the AV node is holding the electricity before, okay, triggering the ventricular depolarization. Now this is an important point, the beginning of the isovolumetric contractions. This is the beginning of the systole. Okay, you have the, well, first of all, isovolumetric, you have a squeezing of the heart. Notice the sudden increase in pressure, okay, in the ventricle, left ventricular pressure in green. But when you look at the volume in the ventricle and in the aorta, nothing happens. They are like a flat line. You have the S1, auscultation. Okay, you have the QRS. And then we have something here that is the venous pulse. That is something a bit more complicated to understand. We are not going to dedicate time to that now. But this is simply what is happening in the jugular vein. Okay, when you look at the jugular vein of your patients carefully, okay, you're going to see that the pulse in the jugular vein is not like a single bump, it's like a double bump. It's like, look. Okay, those are the waves that you have there, the A and the C. Remember, there is no valve between the atria and the jugular and the veins of the neck. Okay, so when the blood, okay, enters the atria and the mitral valve closes, that will produce like a, oh, what's going on? And then when the ventricles contract, the mitral valve is going to bulge, and that's going to produce another little bump. Okay, that is what is happening there. Okay, then we have, after the isovolumetric contraction, the rapid ejection. It starts with the opening of the aortic valve, as you see there on top. Okay, aortic valve opens, and we have still the pressure is increasing in the ventricle. Okay, Now notice when you go to the volume in the ventricle, it goes down very fast and then slowly, but notice in the aortic blood flow. That means that the volume that we are losing from the ventricle is going up in the aorta. No? You have volume decrease in the ventricle, flow increasing in the aorta. Notice that this is milliliters, this is liters per minute. We are measuring different things. Okay? In one, we have a decrease in volume. In the aorta, we have an increase in flow. Okay? Liters per minute. It's very fast at the beginning, then it's less. And well, we have here the systole, between S1 and S2. Okay, and we have in the EKG the ST segment during all this period. Now, what happens here? Reduced ejection is exactly where the T is, and at the end of the rapid ejection or of the ejection period, okay, we are going to have the closure of the aortic valve, the S2, as you can see here. Okay, you have this is at the end of the T. Okay, and notice that the flow in the aorta, the volume in the ventricle doesn't vary. That's why we call it isovolumetric. Okay, and we have a decrease in pressure in the ventricle. It's isovolumetric relaxation, pressure goes down until the mitral valve opens. Okay, and that blood enters from the atrium to the ventricle. We start having the ventricular filling that is rapid first, then it's reduced or slow. Okay, and that will be represented by the increase in ventricular volume. Notice that at this point there is no change in the aortic blood flow because the aortic valve is closed. Okay, and that's a way that you study that. It's not something that you learn in a sitting. It's not something that you simply read and look at and, oh, I understand this. It's something that you probably have to go back many times. Okay, if you pretend to memorize that in a sitting or just watching a video, okay, you may watch different videos and some of them can be better, worse, longer, shorter, okay, entertaining or not. It doesn't matter. We are not going to get all that, okay, just by watching a video or understanding something. It's something that we have to go back and go back and go back to really understand why something stays the same or goes up or goes down, okay? And this is very similar. What I like about this, there was something different. Let me see if I catch the difference now. There was something different here that I don't.
Atrial pressure?
The?
Atrial pressure?
The atrial pressure.
Right atrial pressure.
No, that's here too. It's here. I don't know. I found something here the other day and, oh, this is better, maybe, I don't know. They are the same, more or less, but probably because it's more concentrated, no? It's closer, you don't have to be looking, or your eyes don't have to be wandering too much from top to bottom. Like, or maybe because it has systole, diastole. I don't know. I like it, these two, and I put it there. There you have the formulas for many different things that we've been talking about. And this is something that we are going to be talking about very soon. In all these PowerPoints. Blood. Now, we're going to be talking in this part about blood vessels. And talking about blood vessels, we are going to refresh some of the concepts that we were talking before. Okay, we have many different types of blood vessels. Each of them have a different functions. Remember, veins, we were saying yesterday, are the reservoir of most of the blood when we are at rest. Okay, around 70%, 65, 70% of the blood is typically in the veins. Okay, that's what permits when we are exercising to increase the cardiac output from 5 liters per minute to 15, 20 liters per minute. You're gonna recruit all that blood, okay, from the gut circulation, okay, from different veins in the body. We're gonna recruit all that venous blood into the arterial part of the body. Okay, when we have a sympathetic stimulation, we're gonna produce a venous constriction, squeezing blood into the arterial part, so we have more blood circulating. And for example, lungs, when we are at rest, we are not using the entire lungs. We are only using the bases of the lungs to oxygenate all that blood, 5 liters per minute. You can get them oxygenated with only the bases of the lungs. Okay, all the capillaries in the upper part, in the apices, they are collapsed. But when we are exercising, that we start squeezing all that venous blood into the circulation, we are going to open up all the capillaries in the lungs, the ones on the apices. So we have more area to oxygenate all that blood. Okay, there we have the structure of the blood vessels. That is the general structure, okay, of many different blood vessels. They have an external wall that is called the tunica adventitia. Okay, that is mostly connective tissue, fibrous tissue. Notice that this fibrous tissue, or this external layer, has also blood vessels inside. Okay, there are some little capillaries to nourish the adventitia. Okay, these are capillaries that we call vasa vasorum. Interesting name. Vasa, blood vessel, vasorum, the vessels of the vessels. Okay, in the nerves we have something similar, but they are called vasa nervorum in the Latin. Okay, these are important blood vessels that if they are occluded or they are damaged, okay, this is going to end up with damage to the tunica adventitia of the arteries or veins. Then we have the tunica media, that is composed of smooth muscle. And then we have the intima, that is composed of endothelial cells on a basement membrane. Okay, this is the general structure. We are going to see the differences between, for example, arteries and veins. Okay, one of the most important differences is the lumen, the diameter of the internal lumen. The veins typically have a larger lumen. They need to hold more blood than the arteries. When you open a cadaver, okay, you cut the tissue, typically we see the veins that are larger than the arteries, and the veins typically are collapsed. Okay, the arteries tend to be open because they have more, as you see there, the walls are thicker. The muscular layer in an artery is thicker, so they tend to be open in the cadaver. Okay, many years ago, when people didn't know anything about anatomy, about how was the human body inside, it was forbidden. Okay, religious authorities prohibited opening cadavers. They had to study these things in animals. And they would see, you cut out the meat of an animal, and they would see the arteries open but empty. Of course, all the blood goes away. And the veins were collapsed and they contained blood. And they would think, okay, in those years, well, the veins are the ones that carry blood, and the arteries are the ones that carry oxygen or air. Because artery means air, or conducts for air. Artery. They would think, okay, we breathe, air goes in, travels in the arteries, and then goes to the muscles and produces like a pumping action in the muscles. They would think that. Like muscles contract and relax because of the pumping action of air. When you're exercising, you breathe more, right? That air is the one that makes the muscles, okay, relax and contract. Those were the thinking or the ideas, okay, many years ago. So how do arteries and veins compare? Okay, the size, the diameter, the lumen, the wall that is thinner in the veins, the presence of valves in the veins. Okay. And then we're going to be seeing some other differences, okay, because there are different types of arteries. And we have to understand, for example, the difference between elastic arteries and muscular arteries. Elastic arteries are the ones, the aorta and the arteries that are very close to the aorta, the branches, okay, the brachiocephalic trunk, the common carotid, okay, the pulmonary artery, or the celiac trunk, the ones that are closer to the aorta. These are called elastic arteries. They have a very thick tunica media, okay, and this tunica media has more elastic fibers than smooth muscle fiber. There's more to withstand, to absorb the energy, okay, from the ventricle. They have to distend to accommodate all that blood and then recoil, okay, to push, to squeeze all that blood through different arteries in the body. Okay, it's very important, the distension, the elasticity, and the recoil. Now, muscular arteries like brachial artery, radial artery, femoral, they have more muscle than elastic tissue, and their function is to distribute the blood through to arterioles of different organs, okay, directing the blood flow to different body parts depending on the needs. Okay, then we are going to see how this happens, because for this is very important, the local regulation. Okay, let's say we have blood going through the radial artery, and that blood is going to take through different arterioles. Where is going the blood? To the area where there is more vasodilation, because there is less resistance. Okay, if you have to, say you have two streets, okay, you're going to your house and there is one street here, one there, you can take either or, and there are a lot of cars, there is a school, and all these 15 miles per hour. Oh, no, I'm going this way. Doesn't matter that it's longer. Okay, we're going to take the pathway of least resistance, exactly the same the blood does. If there is a branch, and there is vasoconstriction here and vasodilation here, I'm going this way. Okay, I don't want to be fighting with other red blood cells there and with endothelial cells. Okay, so the muscle, let's say we are exercising, we are doing biceps. Okay, we are in the gym doing biceps, the biceps is contracting, the triceps is just relaxing. Okay, so we are going to have, because of the metabolism in the muscle, the CO2, the lactic acid, all the blood vessels in the biceps are going to be relaxed. The triceps, basal. I'm not doing anything, just yielding, just letting the relaxation occur. So the blood is going to go to the biceps and not to the triceps, because of this vasodilation in one part and vasoconstriction, or simply no dilation in another. Now this is just representing the role of the elastic arteries withstand, okay, the pressure during systole and then recoil during diastole. Okay. Now there is a very important concept, that is compliance, okay, which is a key factor for absorption of energy. Compliance simply means the amount of energy, okay, that, or the amount of expansion, okay, that an artery, for example, this applies also to the lungs, this applies to anything that is elastic, okay, the amount of distension or relaxation, okay, that any tissue has for certain amount of pressure. If I apply a pressure, let's say, of 50 millimeters of mercury, and the tissue yields 10 centimeters, oh, there is a high compliance. But if to get the same effect, I need to apply 1,000 millimeters of mercury, that is not compliant. That is rigid, that is stiff. Okay? When we are born, when we are healthy, when we are young, our elastic arteries are very compliant. They expand easily when the heart pumps. With age, with atherosclerosis, with fibrosis, they become stiff, so they are not compliant. The heart pumps and they don't yield, so the heart has to work harder, okay, to overcome that stiffness. Okay, so we are losing the compliance. And let's compare also. Imagine you are trying to inflate a balloon. You have a balloon and a paper bag. What is easier to inflate? The balloon or the paper bag? The paper bag. the paper bag, the balloon, you have to, at least at the beginning, you have to, oh my goodness, it hurts here, no? So the paper bag is more compliant. But then what happens when you release them? Who is gonna go back to the original size, to the original state, easier? Okay, because the balloon has lower compliance, but it's more elastic. The balloon recoils easily, the paper bag doesn't. Okay, so compliance is important, but the elasticity is important as well. Because you mind that you pump blood, the aorta opens and then doesn't recoil. You don't develop the diastolic pressure. Diastolic pressure is going to be so low that we don't have pressure actually, because we need that recoil when the aortic valve closes to squeeze the blood inside the elastic arteries towards the muscular arteries so they can distribute the blood flow. If the aorta and the branches remain open, like a paper bag, the blood is not going anywhere. It's going to stay there. Okay? And that's not good for life. Because that diastolic pressure squeezing arteries is what guarantees that we create enough pressure distally and we guarantee the perfusion to different organs.
Professor, with aortic stenosis, it's the same thing. It loses the compliance, right?
The aortic stenosis is about the aortic valve. Okay? Aortic valve is the orifice of the aortic valve, not room.
Oh, okay.
Okay? What happens in the aorta that loses the compliance is stiffness, is calcification, accumulation of atheroma plaques, fibrosis, becomes stiff. If you look at if you participate in any autopsy of a very old person that has atherosclerosis, fibrosis, calcification, mostly calcification, and you touch the aorta, and they give you the opportunity of doing this, it is like an eggshell. Okay, if you see a very old person with calcification, it's like you're touching an eggshell, and you can clack. You press it, cracks exactly as an eggshell. Okay, because of the calcification. Imagine how stiff and how, at the same time, weak, because any sudden increase in pressure or any trauma make it break down.
So, can we say that compliance is inversely proportional to elasticity?
It's the contrary. It's the contrary of elasticity. Low compliance is stiffness. Okay? High compliance is elasticity. Okay? And low compliance is stiffness. Now then we have the arterioles. Arterioles are very tiny. Okay? Arteries, the lumen typically is less than 0.5. Okay, 0.5 millimeters, and they are mainly composed of smooth muscle. They don't have any other component. Let me show you the picture of this. Okay, and they typically regulate the blood flow into the capillaries. Okay, where is the arteriole? Look at the arterioles. Okay, they mainly have smooth muscle. They don't have too much of this connective tissue, just a tiny bit. Okay, so the predominant thing they have is smooth muscle. And these arterioles are the ones that regulate, okay, the blood flow into the different areas, for example, of the organs. Let's say we are in the brain and we have an area that is working more than other areas, the visual cortex, because we are watching a movie. So the arterioles that go to the visual cortex are going to be more open than the arterioles that go to other, maybe equilibrium or areas that process other stuff. But they regulate the blood flow within the muscles, and they are the major determinants of the vascular peripheral resistance, of the blood pressure at the end, okay, that is determined by the cardiac output and the peripheral resistance. And the capillaries are really, really, really tiny. they contain a single layer of endothelial cells. And there are different types of capillaries, okay, as we are going to be seeing after the break. Okay, after the break, we are going to be seeing the different types of capillaries, where they are located mostly, what is their function, okay, and we're going to go back to different methods of transport across the capillaries. We're going to be revisiting these concepts over and over, okay. They are really tiny, okay. The capillaries are so tiny that the blood cells have to squeeze, okay, to pass through them, have to pass one by one. I think there is a picture you can see there, okay, which you can see the red blood cells one after the other, like in a line, okay, and how they have to squeeze, okay, their walls, okay, against the capillary walls to have this exchange of substances. Okay, let's have a break, 10 minutes, okay, to continue with the rest of the even if the person is healthy, he's going to have less elasticity. Like we have less elasticity on the skin, and we have wrinkles, and we have like saggy skin. Okay, just like you have a piece of clothes that is, even if it's very expensive, there's more it's going to be like, okay.
Yeah, it's just gonna, thank you.
All the numbers,
Tiny. They are smaller than that. Numbers, figures. Okay, elasticity is necessary for compliance, but it's not the same. Okay? When we say something is elastic, it's that we can stretch it and it goes back to the original size. You have a rubber band, it's elastic. So we stretch it and then when we release it, it goes back to the original size. But something can be compliant and not necessarily elastic. Okay, compliance is the amount of stretchability only. Okay, now elasticity is stretchability plus. How we say something to stretch, that is the compliance. Now, if it recoils, it's because it's elastic. If it doesn't recoil, it's not.
no. Okay. All right. I haven't answered. At least get 3 calls. I just there was a question. I was curious. I thought that veins didn't or is it just
Veins? Of course, that do veins.
So
Who told you they don't?
I must have taken things.
Because that is one of the main characteristics of veins. If they don't have valves, valves are what allow the blood to go up and not return to the legs, for example, when we are standing.
So arteries just work with the pressure. Veins also work through the valves.
And the muscle contractions, right?
There are different factors. Okay, this is a vein in the legs.
Yes.
Okay, so we are standing.
Yes.
Valves that are like this. Okay. Let's say we are standing and blood is going through the arteries down, capillaries, and then goes here. So you have an increasing pressure here, and it's greater than this pressure in this segment. This pressure greater than this opens the valve. The blood goes up. Now, when the pressure here is greater than this, the valve closes. Now you have a build-up in pressure here that opens this, and the same thing happens.
To prevent like
And why we develop varicose veins? Because these valves don't work. If these valves start not working, then you have to. One of the main things that distinguishes arteries from veins is the presence of valves.
so arteries don't have growth. a question.
Professor, only extremity,
Every part.
and the trunk too? Yeah?
Well, the large veins don't have, but the smaller veins, not the large ones, the vena cava, which does. But all the smaller veins, it does. Not the jugular, but the smaller veins that go down from the vein, they do. Not the jugular, not the large veins. But the smaller veins, yeah.
Alright, okay. So that's a good question. Are we gonna learn about, we're gonna use S1, S2, S3, S4, right? Are we gonna learn about?
No, that's in pathophysiology.
We're
We are
learning,
only S1 and S2.
but I saw S3, S4.
Yeah, but that's why I thought this is not physiological, that is for
So
pathophysiology.
worry about S1, S2.
Physiology is normal.
And then M1, M2, T1, we're gonna learn that.
What do you mean M1, M2, T1? What is that?
That's part of the heart, no?
M1, M2,
No?
M?
M1.
What is that?
I learned it when I did scratch. You hear the heart when you're occultating, and you hear the M1, T1. No?
Oh, wow, that's how we call the sound in mitral trachea.
Right.
It's physical, that is physical diagnosis.
That's physical diagnosis. It's not physiology related.
Yeah, well, could be, but that's more physical than I'm going to cover.
Thank you, Professor.
Fresh, so that's what's good.
Yes.
With the elasticity in the compliance.
Because for something to, okay. Elasticity is the capacity to stretch and recover. Compliance is just the stretch. Okay? Something may be compliant and also elastic. Some things are compliant but not elastic. You take a rubber band, it's elastic because you stretch it and it goes back. But if you take a piece of, say, film, the plastic film that we use for food, for example, and you apply pressure, you stretch, it's not going to return to the normal shape. No. They are different properties of the material. Low compliance
And the high compliance, the vessel is elastic.
is stretchable. Stretchable. When you say elastic, is you stretch and go.
Why do they always clean the girl bathroom? Never.
Okay, let's continue. Okay, something that I always recommend to the students is we are studying things that we have never seen ever, and in the future we are going to be studying diseases that maybe you have never heard about, and probably you will never find in real life. Okay, so for understanding things, sometimes we can read, sometimes we can listen, sometimes we have to do. You don't know how to cook something if you don't try to cook it, just by reading a book. And sometimes we have to see, okay, how things look like in real life. How do we know the difference between arteries, veins, capillaries, venules, arterioles, if we have never seen them? Just, oh, this is the size, this is what they do, okay? For example, this is an electronic microphotograph, okay? They have like dissected all the vascular structures in the choroid layer in the eye, okay? So you understand what, and you understand when we talk about the cross-sectional area of the capillaries, remember we said, if you add their diameters, one by one, all of them together, we have this huge cross-sectional area, okay? Here you can see what that means. Look at the size of the arteries and veins, the size of the arterioles and venules, and their location, and look at the extensive network of capillaries, okay? And these are the capillaries that are going to be nourishing or sending oxygen to different cells that are located in that tissue. They are going to pick up the CO2, and they are going to pick up all the wastes that the tissues are producing as a result of the metabolism. Okay, then when you study the different organs, the function of the different organs, okay, you can see what this means. So we were here, okay, talking about the capillaries. We were saying that they are of different types, okay, and they allow the movement of substances, okay, from the blood to the tissues okay, substances that tissues need and collect, okay, all the wastes or all the things that we typically need to eliminate, okay, and they need to allow a very rapid exchange of substances. That's why these capillaries have squamous cells, a single layer of squamous cells, okay, that allows a very rapid transport of substances. Now, the transport across the capillaries will occur by different mechanisms. Okay, one of them is bulk flow, in which we move water and solutes at the same time, okay, through the capillaries. We are going to see that this happens because there are different types of capillaries. Some of them have the endothelial cells very tight together, okay, forming, for example, the blood-brain barrier that doesn't allow anything to move through. But other capillaries have separations between the cells. Other capillaries have fenestrations. So we are able to move, okay, large amount of substances, water and solutes together. Okay, that's something that we call bulk transport or bulk flow. Or sometimes the substances pass using transcytosis. It has to pass through one of the cell membranes, across the cell, and then the other cell membrane. Okay, so when we have questions about the mechanisms of transport, make sure that you know what the question is asking. Are we asking about transport across the cell membrane, one single plasma membrane, or are we talking about transport across the epithelial membrane? It has to move in between the cells, or has to move through the cell, has to pass one and then the other of the cell membranes. Then we have also the movement by endocytosis, exocytosis. Small substances are moved by pinocytosis. Then we also have the phagocytosis, all these different mechanisms that allow the movement of substances. So here we have on top the comparison between elastic arteries, muscular, and arterioles. And below we have the different types of capillaries. Okay, they are classified as continuous. Okay, the cells are very, very tightly joined by these special junctions, tight junctions, different other types of special junctions. Okay, look at the endothelial cells, how there is almost no separation between them. In the center you have the fenestrated cells with little holes that will allow more substances to move through. Okay, and on the right side we have the what we call the sinusoids that have huge gaps in between the cells. There is an incomplete basement membrane that also will facilitate the movement of different things, large things, okay, from the blood into the organs and vice versa. Okay, this is a representation of the different types of capillaries. Okay, these are electronic microphotographs. Okay, on top you have the continuous capillary. This is from the rat diaphragm. Okay, notice that you have some vesicles, pinocytic vesicles that are moving, okay, through the cells. Okay, notice the tight junctions in between the cells. There is almost no separation. Okay, here we have the muscle. In between we have the collagen, basal lamina. There is almost no way for movement of things between the cells. Notice the pinocytic vesicles there. In the center with the V, we have a fenestrated capillary in a rat pancreas. Okay, we have endothelial cells. Notice that there are some little holes or fenestrations. Okay, and that's going to allow the movement of larger proteins. For example, the pancreas has to release proteins, has to release digestive proteins, okay, in order to facilitate digestion of proteins or fat or different things. And below we have the discontinuous capillaries, a sinusoid in the liver. Notice that there are huge gaps. Okay, the liver has to take big proteins from the blood, has to release proteins, big proteins like albumin, etc., to the blood. Okay, and so we need a larger space for these proteins to move through. And here we have more views about that. Okay, we have on the left side, okay, we have a capillary, okay, myocardium. Okay, you have endothelial cells that are continuous. okay, joined by tight junctions. And you can see also pinocytic vesicles, like in the previous slide. Muscle is around. And here on top we have a kidney, okay, and we have the fenestrations. Okay, you can see different organelles. You can see the nucleus. You can see the centrioles, Golgi with the G here. And the arrows are pointing at these fenestrations. And below we have a liver sinusoid. It's also in a rat, okay, with the open fenestrations or sinusoids. Now the capillaries, as you saw in the picture that we saw before, the choroid layer, form networks. Okay, these networks are very important in helping to distribute the blood, okay, within different tissues, different parts of the tissues, taking the blood from some places and sending blood to other places. For example, in the lungs, if we have, let's say, someone has an aspiration of a foreign body, and the foreign body goes into a small bronchiole, so there is an area of the lung that is not receiving air, it's not receiving oxygen. What is the purpose of sending blood to that area if there is no oxygen? It's like going to work in a company that is bankrupt. They're not going to pay me. So what I'm going to be, why will I waste my time working for people that is not going to pay me? They are going to close in 2 or 3 days. The same thing happens in our lungs. Our lungs are not going to waste blood, sending blood to an area with no oxygen. So any area of the lung that has no oxygen, okay, that lack of oxygen will lead to constriction, okay, of the blood vessels there. So we can deviate the blood to areas that are well oxygenated. And this happens because of a combination of actions, okay, of different blood vessels like arterioles and the meta-arterioles, okay, that exist in these capillary networks. The capillary networks contain a channel that is called a meta-arteriole, and then what we call the true capillaries. We are going to see that in pictures later. Okay, and we are going to see the differences between the meta-arteriole and the true capillaries. Now, capillaries have no smooth muscle cell. They simply have endothelium, as we saw in the pictures. Some of them are, well, basal membrane, but in some cases the basement membrane is discontinuous, as, for example, in the sinusoids. We are going to see the function of the precapillary sphincter, okay, that is located where the capillaries branch from these meta-arterioles. And these sphincters are the ones that regulate the blood flow, are the ones that open or close to divert the blood flow to different places. Okay, and they also help to maintain the blood pressure, okay, when we are in any kind of situation of blood loss, okay, hypotension. Epinephrine is going to close many of these capillaries, or the precapillary sphincters, so we don't waste blood in areas that are not necessary for survival. For example, in the skin, in the gut, in the reproductive functions, okay, or in the immune functions. Okay, we typically reserve the blood for the brain, from the heart, for the heart. Okay, here we have the pictures that we saw before about the size and the movement of cells in the capillaries. And here we have a representation of this capillary network. Okay, we have an arteriole that comes from the heart, contains oxygenated blood. And then we have in the center here, okay, what we call the meta-arteriole or through-fair channel, okay, that will take the blood, okay, to different, to a vein directly, or to a venule in this case. Notice that we have there the precapillary sphincters. So, as it says before, in the areas where the capillaries branch from this meta-arteriole, so we could close the precapillary sphincters, all of these precapillary sphincters, to make the blood go directly from the arteriole to the venule without circulating in this capillary network. If there is a tissue that doesn't need oxygen because it's at rest, okay, we don't need to send the blood to this tissue. We simply close those meta-arterioles, and the blood goes from the arteriole to the venule without, okay, traveling through that tissue. And so we can use the blood for other better functions. So let's remind that this is in the intestine. Okay, this is a capillary network of the jejunum, the ileum. Okay, we are doing digestion. Okay, all of this is going to be very open. There is a lot of circulation here, getting nutrients from the small intestine, providing oxygen, etc. And suddenly we have an emergency, fight or flight response, epinephrine is released. All these capillaries, okay, are going to be closed. So the blood that goes to the intestine, instead of trying to get food, nutrients, is going to go directly from the arteriole to the venule, and from there to the general circulation, because we need that blood, okay, for other functions, for fight, flight. Same thing if this is instead of the intestines, this is in the skin. And we enter in a very, very, very cold place. You don't want to be sending blood to the skin superficial layers when you're in a very cold place, because you're going to waste, you're going to lose heat, and we need to conserve. Okay, so thermoregulation will initiate a response that closes, okay, all of these meta-arterioles, so we remove, okay, the blood from the skin and we conserve heat. Contrary happens if we're in a hot place.
Is that why people turn blue when they're cold?
Yes, exactly. That's the reason. Okay, because the lower the temperature, the more of these capillaries are we gonna close, and sometimes not even, because we're talking about the meta-arterioles and the previous capillary sphincters. But this can start happening. The arterioles themselves, they close. Okay, so it's just before the capillary bed. So we may not be sending any blood to that area. That's why we have this cyanosis, distal cyanosis in the nose, in the ears, fingers, in the toes, that may happen. So now we need to go to the part of capillary exchange. Okay, how the capillaries function in this exchange of substances, how this happens. And this will occur differently depending on what capillaries we are talking about. In the brain, there is almost no exchange because those capillaries are tightly closed. Okay, when you have a continuous normal capillary bed, okay, normally we have a single layer of tight junctions, but when you go to the brain, there are 5 layers of tight junctions between the endothelial cells. So almost nothing can enter the brain without permission. Okay, there are just some substances that are free to pass. Okay, what we call the blood-brain barrier. Of course, oxygen will be totally free to go there. It's more than welcome. Glucose, of course, is going to be more than welcome to go there. Okay, ketone bodies, of course, they are welcome too. Small, tiny amino acids, fatty acids, things that are necessary for the brain function. Some medications. Generally speaking, everything that is fat soluble may enter the brain. Because a protein cannot enter in between the cells because it's impossible. 5 layers of tight junctions. Proteins cannot enter through the cells because they need a transporter. And unless the brain has transporter for that, that's not going to go there. Now, lipids will. Steroids will. Because they go through the cell membrane. Okay? Anything that enters by simple diffusion is going to be able to enter the brain. Alcohol, for example, is welcome there. It's a non-polar substance. It's going to go into the blood and it's going to pass to the brain like immediately. Mm-hmm.
So for like the metastatic lung cancer that goes to the brain, how would that work?
That's another interesting topic, how that happens, how bacteria get there, how viruses get there. They typically trick the brain. Metastatic cells typically cover themselves with
Lipids?
our proteins, or with platelets, or with our lipids, and they may be even transported, maybe even neutrophils may take them there, viruses or bacteria, or may be disguised as our cells. Another thing is that they may break the blood-brain barrier because they produce substances that are proteolytic, they may, and there are different mechanisms for that. Okay. So, and the exchange is going to be different, for example, at the level of the lungs, at the level of the intestines, different things are moving in and out. At the level of the kidney, it's going to be different. The liver, spleen, okay, bone marrow. But generally speaking, okay, we are going to use certain rules, okay, that help us understand how all this happens. Okay, we are going to be trying to understand how fluids or good things move in one direction and wastes move in the other direction. So we have to put together many of the principles that we have studied before. And remember, most cases, the transport of substances is gonna occur from high concentration to low concentration, or from high pressure to low pressure. So we are gonna be talking about differences in concentration and pressures between different compartments across these capillary walls. Okay, there is a combination of forces that push substances out of the capillaries or pull or retain substances and water inside the capillaries. Combination of hydrostatic pressure that is given by the blood pressure, okay, and oncotic pressure that is a type of pressure that is given by the amount of proteins that we have in the circulation. And of course, then we have also osmosis, we have all these other pressures, all these transport mechanisms that we have studied before. So the combination or the balance between these pressures is what is going to determine the rate, okay, at which the exchange of substances occur. We are going to be seeing that if you go back to the capillaries, notice that the capillaries have like two colors, okay? One is more red, the other is more blue. Okay, the part of the capillary that is close to the arterioles, okay, contains more oxygenated blood, and the part that is distal or more proximal to the venules contains deoxygenated blood. We are going to see how the rate of transport differs in the area that is closer to the arteriole versus the part that is distal or more proximal to the venules, the venous side of the circulation. So we are going to see the interaction between the hydrostatic pressure gradient is going to be greater in the arteriolar side than in the venous side. It's a very important difference in pressure there. Okay, this is the physical force of the blood, okay, against the walls, capillary walls or any blood vessel wall. The plasma within the capillaries have typically a positive hydrostatic pressure, which is, remember, the remnant of the blood pressure. If you look at the diagram that we were looking yesterday with the pulse pressure, remember the pulse pressure was going down, 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 until we reached the capillaries. There was a tiny bit, still tiny bit of pulse pressure, like pushing, okay, the fluid out. Every push, tiny push will represent a force sending the fluids out of the capillaries. Now, that fluid is going to enter from the capillaries into the interstitial space. Remember, the interstitial space has almost no proteins. We have tons of proteins inside the cells and tons of proteins in the plasma. Albumin is the most important. Okay? So in the interstitial space, there is almost no protein. And when we put that fluid in the interstitial space, that fluid is going to create an increased pressure in the interstitial space, hydrostatic pressure, that normally is going to oppose, okay, to the filtration of more fluid. But what normally happens? In the interstitial space, we also have lymphatic vessels. Every time you have an increase in pressure in the interstitial space, that fluid is going to move into the lymphatics, creating again a negative pressure in the interstitial space, so we can put more fluid there. Okay, so we have this small pulsation, okay, of the hydrostatic pressure in the capillaries. Every time it goes up, fluid moves from the capillaries into the interstitial space, increasing pressure there, but that fluid moves into the lymphatics. And then we have again another process of fluid from the capillaries to the interstitial space, lymphatics, and to the rest of the body. And that cycle repeats and repeats and repeats over and over again. Now, we don't lose all the fluid from the capillaries into the interstitial space. We keep, most of it still in the capillaries, because the proteins that we have inside the blood vessels, albumin, act like a force that pulls the fluid and tries to retain the fluid so it doesn't escape. So we have different factors there. Hydrostatic pressure pushing outwards, oncotic pressure retaining the fluid, and a very important one is the vascular permeability, how close the cells are. Because if the cells are separate, all the fluid will go out. Even albumin can go out, and cells, and proteins. So the three factors have to be in balance for us to just filter a small amount of fluid, retain most of it, and allow the exchange of substances. If one of these things fails, for example, if we have exaggerated hydrostatic pressure, there is going to be more fluid going out than the one that we retain. And when this amount of fluid surpasses the capacity of the lymphatics to reabsorb it, we are going to have accumulation of fluid in the interstitial space, and who knows what is the name of that? Edema. And what happens if we have low content of albumin in the blood? What do you think? We are going to have more forces pushing out or retaining? Pushing out. Because we are losing the albumin, that is the one that retains the fluid. So there are situations in which people don't have enough albumin in the blood, and they are going to lose more fluid than the fluid that the lymphatics can absorb, and this also produces edema. And who can tell me 3 causes why people may have low albumin in the blood?
End-stage renal disease.
Renal disease,
Trauma.
liver failure, one more,
Trauma.
albumin, trauma,
Oh, malnutrition.
nutritional problems. Nutritional problems. Nutrition, because in order for, the liver is the one that makes albumin. And albumin is a protein. And we can't make a protein if we don't have amino acids. And we don't have amino acids if we don't eat proteins that contain those amino acids. So nutritional problems, liver problems, and who can tell me, who said kidney problems? What exactly type of kidney problem? Huh? Nephrotic syndrome. Why? You lose it. Okay, I lost it. The liver is capable of making proteins to replace all the proteins that we lose, but up to a certain point. If we lose a tiny amount of albumin daily, the liver has no problem with that. It makes more. But when the kidneys are losing more protein than the one that the liver can make daily, then we start having an imbalance. Debt. Credit score. That's what happens. The liver is unable to make more than 3.5 grams of albumin per day. So while the kidneys are letting go 1 gram of protein or of albumin daily, that's not a big deal. Liver works more. 2 grams daily, that's not a problem. 3 grams daily, don't worry. I will make 3 grams daily. Balance is maintained, and losing that amount of protein daily, 3 grams of albumin daily, is what we call nephritic syndrome. That's for pathophysiology. You're not going to be tested on that. Now, when the kidneys let go more than that, 3.5 grams per day, now the liver says, okay, I only have 2 hands. I can't do more. Find me another liver. And we can't put another liver there. There is no room. So now we lose, let's say, 4 grams of proteins daily through the kidneys. The liver makes 3.5. 4 grams, 3.5. 4 grams lost, 3.5 made. There is a moment when the albumin in the blood goes down and is so low that we don't have enough oncotic pressure to retain water, and we develop a generalized edema. Okay, because we start losing fluid, okay, from all of these capillaries that the lymphatics are unable to pick up and retain. Now, vascular permeability typically increases as a normal response when there is inflammation. Okay, if you remember the 4 cardinal signs of inflammation, which are 4 cardinal signs of inflammation?
Heat, temperature,
Heat, what else? What else?
redness,
Redness, swelling,
Tenderness.
pain, tenderness. Okay, so when you have an area that has an injury and it becomes swollen and red and hot, painful, it's because something is going on there. Okay, pain because of the injury, the damage. Cells are broken, they release chemicals, and these chemicals stimulate pain receptors. Now the swelling, the redness, the heat is because we have vasodilation. Okay, vasodilation will separate the capillary, the endothelial cells. They are normally like this, and we separate them, and they contract. So we now leave tons of space in between the endothelial cells. And will allow water and proteins like antibodies and albumin and fibrin to move out, increasing the oncotic pressure in the interstitial space. Now the interstitial space is the one that has proteins and is pulling water out and more proteins out. We need antibodies there. Okay, and that will lead to the edema, swelling. The dilation of the blood vessels makes the tissue look red, and if you touch it, it's hot. Okay, now this edema is going to compress the venules, and the compression of the venules is going to increase the hydrostatic pressure inside the vessels, and it's going to push more fluid out. It's going to make it more swollen. Because now we have to separate more the cells, because we need the neutrophils to move out to fight any infection that is there. Okay, and that's why we have to put ice, we have to take ibuprofen, we have to do things to reduce that inflammation and make the blood vessels constrict a little bit, but it's not too swollen. Okay, that's the reason for this treatment, for these signs, symptoms that we see. So here we have an example of the different things that happen in a capillary. You have the arterial end, and then you have the venous end at the end. And remember, the oncotic pressure is given by the concentration of proteins. Okay, so you have something happening at the beginning of the capillaries. There is a very high hydrostatic pressure that is going to push fluid out. So when you move to the center of the capillaries, you're going to have less water and the same amount of proteins. So now you have albumin more concentrated. Okay, so you start having a decrease in hydrostatic pressure and an increase in the oncotic pressure, because we have the albumin more concentrated and we have less fluid. So there is a moment in the center of the capillaries in which the forces that push the fluid out and pull the fluid back are equal. So we have a net filtration pressure of 0. We don't have neither filtration nor reabsorption there. As we move on to the venous end, okay, we are going to have in mind on this side you have the venules that have a large diameter. So all this blood that is here is going to an area of low pressure in the veins. And add to this the pumping action of the respiratory system, creating a vacuum in the veins of the chest. Okay, and the pumping action of the muscles in the legs or the arms. So here we are going to have a hydrostatic pressure that is very small compared to here or there. And we are going to have the same oncotic pressure. So at the end of the capillaries, we are going to have the reversal of the process. Okay, now the forces, okay, that exist there favor more the reabsorption of the fluid, okay, than the filtration. So we filtrate in the arterial end of the capillaries and reabsorb in the venous end of the capillaries. Of course, we don't reabsorb everything that we filtrated, and that's why we have the lymphatics to take care of the excess that was left, and also to pick up the proteins that we release or anything that we have lost. Okay, and this is following, okay, certain laws in physics that we call called Frank-Starling mechanism, or Starling forces, has different names. Well, we are almost getting to the end of this part of the cardiovascular system. We only have to look at regulation, okay, of all these things. Okay, here we have a review of many of the things that we have been talking, okay, in the past, yesterday and today. Okay, we have the different blood vessels with their different functions. Veins are storage blood vessels. They are called capacitance vessels. You can increase the capacitance or capacity. Okay, sometimes we use fancy jargon that we could understand better by using the regular word. They are capacitance because they have more capacity. No? You can dilate them to increase the capacitance, or constrict them to decrease the capacitance or capacity. Okay, the most important capacitors, or the ones that can hold most of the blood, are the vessels that we have in the abdominal cavity and pelvic cavity, that we know as splanchnic vessels. They hold most of the blood during the entire day. Okay, then we have the heart, the aorta, that is a vessel with high compliance and elasticity, withstand the pressure from the ventricles. Then we have the distributing arteries, branches of the aorta. Then we have the small arteries, the arterioles, capillaries, venules, all the circulation there. Okay, below you have represented the main function of these blood vessels. Aorta and large arteries distribution, small arteries and arterioles are resistance vessels. Okay, the main determinants of the peripheral vascular resistance and blood pressure. Then we have the exchange vessels, which are the capillaries. And then we have the capacitance vessels. Okay, and on the right side you have a representation of these that we were saying yesterday. Okay, about the pulse pressure. Remember, we were saying the blood pressure has two components. One that is dynamic, systolic, diastolic, and has a static component, that is the mean arterial pressure. Okay, that you can represent as a line. Okay, representing the mean arterial pressure at different points. Okay, you calculate the mean arterial pressure by simply taking the diastolic pressure, okay, and the pulse pressure, a third of the pulse pressure, and you add them up. So someone who has the blood pressure in 120/80, you take the diastolic, which is 80, and the pulse pressure, which is 40. 40 divided by 3 gives you like 13.3. So 80 plus 13 is 93. That is the mean arterial pressure for a person that has a normal 120/80. Okay, this mean arterial pressure is very important too, because, for example, someone who has a mean arterial pressure below 60, okay, they have a very, very compromised perfusion of blood to the brain, to the kidneys, to different organs. So when you receive a patient in the ER, no matter what is the reason, if they have a low blood pressure, the main objective of our job is increase the blood pressure. Okay, increase the fluid pressures, and then we find out what's going on. Okay, but we need to increase the blood pressure, is the priority. So we were saying before that there are some factors at the local level that determine where the blood goes. Okay, and we need to understand what happens at the tissue level. Okay, there are different theories for this, how we know, how the body knows where to send the blood. Should I send the blood to the liver, to the spleen, to the brain, okay, to the stomach? How do I know? To this muscle instead of that muscle? Okay, so there are many local factors, and sometimes you can use some analogies. Okay, let's say you are the mayor or the governor of a state, and you have different places with different needs. Okay, there are different priorities. And you're going to distribute the budget, you're going to distribute the money depending on the needs of different areas, or schools, etc., depending on the needs. More or less, the body works in a similar way. Okay, there are some factors. We divide them into extrinsic and intrinsic. When we say extrinsic, it's not outside, it's extrinsic to the organ itself. Okay, let's say we are talking about the kidney. How we know if we are going to dilate or constrict the arterioles in the kidneys. Well, you can use extrinsic factors like sympathetic stimulation or atrial natriuretic peptide, different hormones, neurotransmitters. This is endocrine system, autonomic nervous system. Okay, so we, for example, increase the amount of angiotensin II in order to produce constriction, increase the vascular tone in different organs. Okay, we can use atrial natriuretic peptide that induces vasodilation. Remember, the function of ANP is to eliminate fluid. So if you want to retain fluid, you close the arteries in the kidneys, so the blood stays in the circulation and the kidneys don't make urine. But if you want to eliminate water, you have to open up the arterioles in the kidneys, so more blood goes to the kidneys and they make more urine. We have these actions between angiotensin II and atrial natriuretic peptide, which are extrinsic to the kidney, and these are sent from other organs in the body. Now, there are some intrinsic factors. The kidney also knows what to do. Okay, but the kidney has a lot of autonomy. Okay, while the blood pressure, the mean arterial pressure is between 80 and 180, the brain doesn't do anything. Okay, it's like the federal government. Well, if everything is okay in Florida, I'm not going to do anything. Or if there is a disaster, I will send the National Guard. No, but otherwise I won't. So while we have a normal mean arterial pressure from 80 to 180, the autonomic nervous system, the endocrine systems don't act. Now, if the mean arterial pressure goes below 80, that's a problem. Okay, but in normal values, the intrinsic mechanisms in the kidney, and this applies to other organs as well, okay, will act to maintain certain amount of blood flow and blood pressure inside these organs. There is a mechanism that is called myogenic. That is very simple to understand. Let's say you want to maintain a diameter in an arteriole. Okay, this is the diameter that I like. Okay, if there is a lot of blood flow suddenly, and there is blood pressure that increases, and you stretch the arteriole, this stretching will produce a reflex that will make the arteriole contract. Remember, stretching opens sodium channels, depolarization, leading to contraction. That's the myogenic mechanism. So you have more blood flow that stretches the artery, it will constrict. If there is too little, it will open up. Too much will close. Too little will open up. That's simply a muscle reacting to different conditions. Now we have some other factors that we call metabolic. Okay, the stretching, not stretching, we could call it mechanical factors, and the rest of the factors are metabolic. Let's say you have an increase in, for example, CO2, or nitric oxide, or endothelin, different paracrines that are produced locally, prostaglandins. Okay, those are going to lead to different reactions. If you have prostaglandins, you're going to dilate the arteries. Remember, if you want to remember that is, okay, if I have inflammation, what medication I take to reduce the inflammation? Who can tell me? The average person. NSAIDs. Ibuprofen, aspirin, Who knows the mechanism of action of NSAIDs? What they block? They inhibit the formation of prostaglandins. Okay, inflammation has heat, swelling, pain, all these. This occurs because of vasodilation. Okay, when there is injury, when there is inflammation, different chemicals are made. Prostaglandins are very important. Prostaglandins dilate blood vessels, produce pain. So I need to block that. Okay, so ibuprofen blocks the production of prostaglandins, reducing inflammation. So that way you remember, okay, that prostaglandins produce vasodilation. And if you inhibit the prostaglandins, blood vessels are going to constrict. What is the application of that? If someone has an ulcer in the stomach, the ulcer needs to be repaired. And to repair an ulcer, I need blood, oxygen, and nutrients. So I shouldn't produce constriction. Because if I constrict the blood vessels, the ulcer is not going to be repaired. So don't give NSAIDs to people with ulcers. Okay, that's the mechanism. If someone has kidney failure, they are producing very little urine, and we give ibuprofen, they are going to shut down the kidney. They're going to worsen it. Those are the things that you have to start working with in your minds. And, well, we have some substances. Nitric oxide is a dilator. How you remember that? Professor told me yesterday that when people have chest pain, we give nitroglycerin. Nitroglycerin dilates the veins. Nitro. Nitric oxide is a dilator. When we give nitroglycerin, we are giving the chemical that the body will use to make nitric oxide. Okay, so nitric oxide dilates. Endothelin, sometimes we have to remember things and memorize things. Endothelin constricts. Okay, we have many chemicals that are produced locally. Okay, histamine, bradykinin, interleukins of different types, prostaglandins, that they typically produce vasodilation. Okay, histamine, for example, is a great vasodilator. And how you remember that? Someone has a food allergy. They have a rash. The rash is red. So there should be vasodilation. What do we take? Anti-what? Antihistamines. We block the histamine action and will produce vasoconstriction. So the rash goes out. What else histamine produces besides dilation? That's why we take Benadryl and we don't take ibuprofen. Because ibuprofen is good for inflammation and pain, while Benadryl is good for inflammation and itching. Because it acts, okay, blocking a different chemical. Instead of prostaglandins, like ibuprofen does, it blocks histamine. But it's the same principle. Okay, once you get all these principles, okay, instead of memorizing, get the principle, medicine becomes extremely boring. Because it's the same thing with other names. The cell that makes a chemical binds to other cell, something happens. We use a medication to block the chemical or to block the cell or to block the receptor. That's medicine. Okay, but you change the names 100,000 times. That's why we have to be so many years studying. Okay, because I have 100,000 processes that are the same with different names. Okay, but it's all the same. Well, hypoxia, CO2, lactate, all these things will decrease the vascular tone. That means dilation. So if you have tissue A and tissue B, tissue A got an injury or is working too much, we are producing CO2, lactate, prostaglandins, interleukins. We are decreasing the vascular tone in tissue A. Blood vessels are opening up. So when the blood gets there, where is the pathway of least resistance? That one. That's too complicated, it's too narrow. Let me go this way with all the people, party, there's a more warm here. There are new people like interleukins, prostaglandins, histamine, how are you? And this and that. For the blood is better to go through the pathway of least resistance. Okay? And then, well, we have some mechanisms here that we can leave for next week. because we are almost 5 seconds away from your break time. Okay, see you next week. Have a great weekend.